Hey everyone, so this is Angie Charlet again, and today we're going to talk about population health management, the financial considerations. And we're going to go into a little bit of a variance with the financial considerations as we go along. And we're going to talk about some innovative ways of thinking, as well as looking at some of that roadmap of where we start with population health. So again, this is me. I don't have my video up, but I figured this is easier to have it as is. So I work with Canopy Associates, and I am assisting Lance Keilers and Connected Healthcare Solutions and bringing this to you. All right, so today our objectives. We're going to look at indicators of success, especially as they relate to finance, because we all know the CFOs, I like to say is show me the money. Create that budget template and work plan that can demonstrate the value of what you are building in your population health program. And then set some realistic goals. Look at ways to measure your goals and tools and demonstrate success while overcoming the failures along the way. And it's okay to have those failures. So first, let's talk a little bit about terminology. In our last presentation, we talked about chronic care management. Today, we're going to be, more focused on population health. And when we think population health, there's a lot of variable terms that can be used. Population health in and of itself, programs targeted defined a specific population, whether it's an individual, an organization, or social interventions to improve health outcomes, such as our chronic care management. Accountable care organizations are those organizations that bring providers, hospitals, and other healthcare providers together to really start to provide coordinated, high-quality care to well-defined populations. A lot of this we know in ACOs is around Medicare, but there are other commercial payers as well that are, joining the club with ACOs. And then we have our clinically integrated networks. That's that structured collaboration among physicians, hospitals, and other providers to really improve access, quality, and efficiency. Very similar to our ACO, just a little bit different model. And then, we have public health. And I don't want people to get confused when they see public health, because public health is definitely an area that needs to be considered when we are building our population health programs. Our public health departments are aimed to protect and improve the health of the communities, in which they serve in various aspects. Another way to look at population health is that transformational care delivery. It's really enhancing and building the high value of care. We have demonstrated quality outcomes, and it's across the continuum. It's all ages when we start thinking about, our entire population in the communities we serve. HFMA has their own definition. You can see here, again, value, coordination of care, engage consumers, reducing costs, starting to sound familiar, a lot like our triple aim, which is now our quadruple aim as we continue to move into the new way of thinking and the way the healthcare dynamics are changing. But simplicity-wise, it's really that aggregation of patient data that we are using, and we are providing multiple resources, as well as analysis of actionable activities, and start to really dig a little bit deeper to really improve the clinical and financial outcomes. But it requires clinical, financial, and operational, not just data together, but really looking at the entire framework of the organization, all the leadership as well as all the staff, really understanding what we are doing as we are shifting from that current fragmented care management initiatives to a totally holistic and structured patient-centric approach. So let's kind of go into our hospital roadmap. Now remember, these webinars are very short and brief. They should last less than 30 minutes, just to kind of give you some teasers, but ways of thinking as we go along. So we start with our indicators of success. Investing in technology is not necessary until your program is designed. So I don't want people to think, oh, it's going to cost me a ton of money because I have to invest in all this technology. And you don't. Really, it's evaluating the staff and what they're doing to work to the full extent of their license. and then consider our current payers, payer mixes, and incentives, obviously, for all that are involved. But really setting that framework, our mission and vision of our population health program. What do we want it to truly look like? And have that full understanding, really engaging and putting it into our strategic plans, having the board engaged and on board with the new direction and understanding the healthcare paradigm shift as we move into these new ways of thinking in population health. We want to identify our key stakeholders. This isn't just our internal key stakeholders. We automatically think our board, our leadership, our providers, but it's also all of those stakeholders that we work with in our community, both our primary and secondary markets. There's a lot of other variables that build into our stakeholders and our resource bucket of who we have available to assist us in building our population health program. Self-assessment. There's several tools out there. The Rural Center, if you go out there, and I know I have their link at the end of the slide deck, there are a lot of really good self-assessment tools you can do internally. If you like other assessment tools, I know Connected Healthcare Solutions has another self-assessment tool that is available for use, or bring on site, and we can do it together collectively. We can also do these, doing them virtually to really capture the true impact of what you have going on. The self-assessments are that foundation of identifying your opportunities, and then start looking at your opportunities and rank them maybe by greatest need or the easiest way to fix, or looking at ones that you think are going to be quick wins, but it really gives us an idea of where we are and where we're sitting. So then we want to look at some of our internal infrastructure in our roadmap. What are our current resources? Both internally with our staff, with our specialists, with our providers. We want to look at current workflow processes. I know we talked about this in the chronic care management section. You really want to enhance what you have. Provider champions and provider engagement. What do our contracts say with our providers, and how can we evaluate that? And then we also have our EHR, evaluation of systems, the capabilities and the staff, looking at the informatics side of our internal infrastructure. What do we have available currently to show data and have that baseline for improvement? And then we have our external infrastructure. What do we have available in the community? What do we have in our tertiary care centers that we utilize? Our EMS services, looking at the staff of ability to do more or to assist in the population health. We want to look at our CHNA if we are doing them. If you're not doing them, I do encourage it, even if it's not required, or to be part of the health department's program, only so you get a really good understanding of what is happening in your market and really kind of drive into some of those social determinants. They truly are our driving forces of disease management in all ages and all capacities. And then potential other healthcare services. Do we have home health? Do we have community health workers? Do we have any kind of services through our churches or religious organizations? Again, really start to evaluate those external components. And then we have our financial indicators, really starting to look at, okay, what can we evaluate? Looking at emergency room utilization. A lot of this comes from, our ACO engagement as well, if we are part of that, or a clinically integrated network. We look at the emergency room. Are they using it appropriately? Are we looking at methods to improve that primary care provider and patient alignment so they are not using our ER as their only source of medical care? Our outpatient services, how often are they using us for their outpatient versus going to tertiary care? Our provider visits, can we enhance our provider visits? And then obviously we all track readmissions. What do our readmissions look like? And how soon are they coming back in? And really start to understand, the value of readmission data and how we can improve that. And then our disease management, again, kind of goes back into chronic care management and transitional care management. The prevalence of diseases, that's our social determinants of health as well. Really starting to look at our markets, our demographics and geographics of where they're located, our COPDers, our diabetics, our obese, and again, looking at the current management practices for these diseases and what do we have available to help our patients to really have a strong sense of self-management and self-control of their diseases and understand those exacerbations or those blood sugars. And then our specialty care services. How often are they coming? Can we look at our specialty care in the framework of telemedicine versus on-site and the value of that? And, again, our financial indicators looking at, the payment. Our preventative service, this is a quick one. And I share this one all the time when we think about it. Vaccinations, immunizations, wellness programs. These are quick wins to bring our patients in. Even if it's only once a year for our Medicare population, it's a Medicare well visit to get them in the door to really evaluate, also get them their influenza, or if they need a pneumonia or a shingles or now COVID, really starting to enhance the care we provide for our population through those wellness programs. All right, so once we have some of those financial considerations kind of quasi-built, then we want to start to set some goals and measurement. And we want to start looking at some of those goals as they relate to finance, as well as, other areas. So in our financial goals, obviously mitigating our costs, whether it's a short-term focus, looking at our ED utilization of services, or the EMS if we own our own ambulance service. And then we have that long-term focus, really enhancing our prevention and wellness programs, our chronic disease management, which also goes into our clinical goals, but really enhancing our patients and patient experience. We want to get into clinical. Are we managing their blood pressure appropriately? Are we monitoring their hemoglobin A1Cs every 3 months? Are they getting it under control? Are they filling their medications? Do they understand their medications? And do we have a full list of what they are taking? Really using some of those evidence-based medicines to create our metrics, some of our protocols and best practices in the care pathways to reduce those unwanted variations in care and overall enhance the patient experience, but also their outcomes. And then, our patient engagement goals, are they getting engaged? Are they evaluating the current healthcare choices within their community? Looking at focused approaches to changing their behaviors, and what they do. And then, we all can relate to patient satisfaction survey implementation strategies. Looking at, are we capturing real-time data? Are we asking them to fill out maybe 5-question card, at the end of their visits, whether it be in our emergency rooms or on a tablet, on a card, it doesn't matter, just to get a quick look at, did we provide and meet their expectations when they were under our care? And then becoming provider of choice. So I use this term often when I talk. It's not just provider as the MD. I want our hospital to be the provider of choice, our lab department to be our provider of choice. It is everything in the healthcare entity and our healthcare world that we are that provider of choice. I highly encourage people to look at the patient-centered medical home recognition. It is a proven best practice success factor. Looking at team-based care and how team-based care really embraces, patient-centric care. Looking at provider champions, it doesn't necessarily need to be an MD. Our providers are also our nurse practitioners, our lead nurses, our PAs, obviously, our anesthesiologists can be also provider champions. Looking at some of those team assignments, who's doing clinical care coordination? Who's following up on our utilization of services? Is it within our emergency department along with the clinics? Break down some of these silos of communication. Really start to engage various people from the entire healthcare entity to build these teams and team assignments. Looking at our community member participation. Have we asked some of our patients, to sit on a committee or a task team, especially ones that are possibly using our ER services frequently versus those that, don't come to our physician practice often. We can look at both ends to see, why are you doing this and how can we enhance it or change it or make it different? Really start to embrace multiple venues to meet the population where they're at. Again, with COVID, this has been quite the challenge as we have started to step outside of the COVID world now and the post era as we are entering. How can we meet our patients in that population in specific marketplaces? Looking at, are there other areas we can meet at? Local churches, communities, centers. And then one of the things that I really try to tout as knowing your risk scores, the hierarchical condition coding. Are we coding them correctly? This is a really quick win if you don't know these scores, to really start to look at your EMR systems and see how you can capture the score if you're not within an ACO or a clinically integrated network, to start to evaluate, am I doing everything appropriate? And am I capturing everything to have the payment model appropriate for reimbursement? So now we're going to go into some of our startup goals. Readmission reduction measures, really looking at what does the reduction measure look like in transition care management. Keep it simple. Let's just start with they've been discharged from the hospital to getting follow-up with their primary care provider. And looking at some simple goals to really start to engage the staff in where we're moving to. Our ED utilization, who are our high resource users? Look at it over a year's time. Is it 4 or more times in the emergency room in a year? Is it 2 or more times in a quarter? Really starting to align our primary care providers with our patients. And then we have seen some best practice models that looking at the urgent care and utilizing our urgent care hours in our ED and in our clinic, and it can be attached to either or. Obviously, chronic care management, and if you haven't listened to the first of these series, I highly encourage you to go back and listen to the chronic care management and really being billable for services and focused disease management. And then starting to build those internal wellness programs. I cannot say enough about, staff engagement in their own wellness, possibly even their families in some wellness programs that we can build that maybe our own insurance company would then assist us in reducing some of our premiums based on staff engagement in their own wellness. And then that reduction in healthcare spend with incentives. So if you want more on that, we can go deeper into that as well. But there are some really good programs out there in engaging the wellness programs in both your internal infrastructure as well as, your community. So then you start looking at, okay, do I need a scorecard? Do I need a dashboard? And how am I going to monitor all of this? And I wanted to give just a quick couple of slides just to say, okay, what's what? Who uses what? So if you're looking at a scorecard versus a dashboard, scorecards are for leaders. They are really that strategic design. The dashboard is how are we doing? Are we getting to the goal? It's the frontline staff and the operations of what we do. And really looking at, how the scorecard manages things. Well, stop for just a second. All right, so as we continue to go through our scorecard versus dashboard, and here's why I want you to kind of have an understanding of the differences. When we look at them, oh, my slide didn't change, there we go. The scorecards really measure and compare your performance against your projections and your goals. That dashboard is helping the staff set their internal goals to meet the quality of care outcome that they are trying to drive. They can also be a little bit more engaging in that they're, I think, in my terms, customizable, but they're user-friendly. They kind of set the stage at your coffee program on top of, really looking at what am I doing to really change the strategic long-term direction of the organization? And how can I make a difference in execution and planning with my scorecard and the dashboard at the staff level? Typically, when we think population health, our dashboards may be on our med-surg area, our ER area, our clinics, really looking at, okay, what am I doing to drive change internally to make a difference in my long-term goal in my scorecard and that strategic plan? So here is an example of some things you could do when you're starting to build that scorecard. When we look at increased days cash on hand, again, these are kind of financial driven. We are tracking our days cash on hand. The US median for rural is 76.26 days. Our current level is 72, and our target level is 82. So where do we want to be in 12 months, and what do we want to look like? These are the ways we can start to set just a few simple areas of tracking on a scorecard. Reduce our readmissions. Again, set that target level where we are at our baseline versus where we want to be in 12 months. Our HCAP scores obviously are, this says hospital compare, it's now care compare, but really looking at that transition of care. The national numbers are still kind of, on that lower end. They really haven't improved much. So I definitely think in our rural entities, this is where we can make a huge difference because of the care and the engagement of our patients, to want our hospitals and facilities to do well. And then reduce our ED frequent visitors, who are our multi-users, and how can we change that? And, the simple ones with Medicare patient alignment. Let's start with something simple with Medicare well visits. And this is a chargeable visit, so we can definitely increase this and have revenue at the same time. And it engages our patients with our primary care providers and kind of sets the stage for our population health ventures moving forward. We also want to look at some of our service line measures, our profit and loss measures. These are outpatient, inpatient revenues. Any adjustments, write-offs, cost of labor and materials, overhead. I don't want you to think about investment measures, as being costly. A lot of the investment measures is truly the training and taking some time with the staff to really engage and have them embrace the strategic direction of the organization. And then we have our operational statistics and ratios. These are those things that we can definitely start to make a change with. And we'll see this a lot in our provider engagement and really looking at our case mix indexes, if we use those scores, and then looking at our patient days, average length of stay. And I would also look at average length of stay by inpatient observation, as well as swing bed, and really start to look at how are we making a difference for our patients. And then our marketing strategies, our brand strength, consumer perception and engagement, looking at our referral locations and the rating of those. When our patients come back to us in the primary care office, ask them what their thoughts were, their experience with their referral, their specialist. What did that look like? How did it feel? Will they go back? Are there things that we need to be doing differently for them, or looking for other possible referral solutions for them for that service that we're looking at? And then we want to look at some peer best practices and a little bit of innovative thinking as you are continuing to build this roadmap and build those financial indicators of success. So with that, you'll see a link, a website here. And like I said, the Rural Center has some really good tools and resources out there. And when you start to set that team and we start to look at the way our team is built, we definitely want to send them on a research path, saying, hey, go read this, and then bring back the cliff notes. What was your takeaway, and what's one thing we could do differently as we start to change our behaviors and the way we do things in our organization? So some best practice ideas that are out there that I have learned, that I have heard from on different organizations that I've talked to over time. Again, patient-centered medical home, cannot stress it enough. It's a easy way to really engage with your community. I also believe that chronic care management is a good stepping stone into this. Don't want to do that one yet. Transitional care management and that whole transitions of care to discharge to the PCP. Very quick wins that we can look at to really engage our patient and primary care provider and create that collaborative amongst the two. Care coordination to enhance the communication with our tertiary care facilities. And this is really looking at them, especially in our swing bed population. How can we really get our tertiary cares to see us as that swing bed alternative versus SNF, which takes us to the next one, SNF versus swing bed. But also looking at, hey, if my patients were discharged from a tertiary care, are they coming back to their primary care provider? Can we do some of that transition care management, and follow up with them for the next 30 days? Our ED follow-up, PCP alignment, again, very simple, very easy to do. Really start to look at how can we engage our patients, show them that, that we care. Quick care clinics, I see those popping up everywhere. And again, these are somewhat simple, but somewhat they can be a little costly depending on where you put them. Look at the resource sites and reach out to some of these quick care clinics and ask them what they've done. I have several in Illinois that have done just a bang up job with their quick cares. Medicare well visits, annual well visits, getting their vaccinations done. These are quick wins to get patients in, especially now that we are going into that post-COVID era, to really start to embrace the PCP alignment as well. Other quick wins that I have seen, are in the lines of employee wellness. New Ulm has a huge project that they started with their employees, and it has ventured into the entire community. And if you have not heard about that, please go on to the Rural Center, but also reach out to us and we will share that. It's just phenomenal what that CEO has done for his small rural community. And then we start to change the way we're thinking. And this is where we're starting to wrap up here. And it's really looking at, okay, what can I do to change the dynamics and look at how I get people embraced and asking different questions. Go from that business thinking model to that innovative thinking model and look for how can we change and really ask the what ifs, instead of, well, this is what it says, this is what standard practice shows us, but then start asking more. And in ways to do that, when we start changing from that business to innovative thinking, getting our teams to pay attention a little bit differently in our meetings, looking at how we can personalize our meetings and the way we think. Imaging, and using imaging as a method to embrace change. Serious play, I do Lego serious play, and it's really using truly Legos as that baseline to change the way we think, and using the Lego tools and the Lego blocks as ways to describe change. Collaborative inquiry and crafting. Again, there's multiple things you can do to help your employees and your team members to really start to look at, different ways of thinking. Reframe your challenge. What is it you're really trying to get for the customer experience? And then we all know about lean and lean improvement methods, and those rapid cycles of change. Sometimes it's better to do a rapid cycle change in something to see if it's going to work or not. Look at how well it's accepted, embraced, or if it's going to have a lot of, not necessarily failures, but roadblocks or stepping stones that you have to get through to make it a success. Truly don't accept comfortable. It's okay to fail and, to be bold, and to allow the staff to really let their mind wander and think about how they could do things differently. These are definitely, you know, things people have heard before, but really helping them to understand and embrace that ability to do so. Well, I'm only going to do what everybody else thinks. Really try to avoid those group think moments in the team engagement. And then I don't know where this slide ever came from, this graphic. I have seen it multiple times. I have it just in my little tools of things because I always liked it. But, it kind of helps you the way you start to phrase some of your questions. What could we look at in a new way? What could we use? We could move, connect, change, or create based on our target. What is it we really want to get to? And then, we have our resources, and I have several pages of resources here for you. And, looking at the Care Coordination Canvas Guide, huge. And there's also a whole workbook that goes along with that. The Population Identification Guide and the Population Health Toolkit, and then, a link to that readiness assessment, that self-assessment. Am I ready to go? What do I need? How does my baseline look for doing this change? And then resources, our locations of data. Where can we find some of that data? And, just get out there and do some research and see what's out there as best practices. Break up the education a little bit as we continue to move this along, and start to look at things a little bit differently. And then marketing to engage our community and start to look at, okay, how do I get my community engaged? What do they need from me? And these are just a few resources to, change up, do what you want, and look at ways to start to engage our community and also let them be aware of what we're doing. All right, so now, it's open time for any questions that you may have. I don't see any in the chat box. I know we've got quite a few people on. So again, this is just a very high level presentation, supposed to be down and dirty, very quick, of population health, where you can start small, start simple, and slowly make your steps forward. Start with one small step and then start to look at your strategic direction. Sometimes it's easier to kind of test the waters ahead of time, and again, simple ones, employee wellness programs, and then really starting to go out and talk to the Medicare population on your Medicare well visits, annual well visits, and getting them in for their screenings. And then you can start looking at your advanced care planning and other needs that they may have. So with that, I hope you enjoyed today. Again, this is all presented through Connected Healthcare Solutions. And there's Lance's information, should you like any of it. And then my information is at the beginning of this slide. Again, I'm Dr. Angie Charlet, and I hope you have a wonderful and blessed rest of your afternoon. Thank you so much.